I want you to imagine, just for a second, waking up tomorrow morning, stretching in bed, and finding that your arm simply refuses to follow the commands from your brain. You look right at your hand, you tell it to open, and nothing happens at all. It's not numb, right? It's just entirely disconnected.
Yeah, totally isolated.
Right. And for about 400,000 Americans every single year, this is the frustrating, completely exhausting daily reality of developing chronic arm paresis after a stroke.
It really is an isolating reality. And honestly, conventional medicine has struggled to adequately address it for, decades.
Yeah.
Because the standard of care has historically been hundreds of hours of just grueling physical therapy.
Which most people don't even get.
Exactly. Most patients never even get access to that because of insurance caps or just geographical constraints. But we're actually looking at the potential paradigm shift today.
I'm very excited about this one.
We're diving into a June 2026 article from Nature Medicine, and it's titled Spinal Cord Stimulation for Upper Limb Motor Function in People with Chronic Post-Stroke Hemiparesis, a Feasibility Trial.
Okay, let's unpack this, because the core mission of this deep dive today is to really understand this radically different neuroprosthetic approach.
Right.
Instead of trying to force a heavily damaged brain to slowly rewire itself through sheer repetition, which takes forever, we're looking at a technology that temporarily bypasses those broken neurological pathways by just plugging directly into the spinal cord itself.
Yeah, that bypass is entirely necessary when you look at the underlying physiology of a stroke.
Right. The roadmap for today is we are going to cover the biological mechanisms, then look at the incredible results from a 7-person trial, the safety hurdles they hit, and finally why your sensory system might be the secret key to all of this. So let's start with the anatomy. What exactly is breaking down here?
So we are specifically dealing with damage to the corticospinal tract. When that main descending bundle of motor axons is damaged, whether by ischemia, so a blocked vessel, or a hemorrhage in the brain, the signal simply cannot reach the anterior horn of the spinal cord to tell the arm to move.
It just hits a dead end.
Exactly. And this corticospinal axon loss leads to a very stereotypical manifestation of hemiparesis.
And it's not just a simple matter of the arm being, weak, right? Because I know stroke recovery deals with a whole cascading series of deficits.
Oh, absolutely. The weakness is really just the first symptom. The patient literally loses the ability to recruit muscle fibers. But the secondary symptoms, they're often much more debilitating.
Like what?
Well, first, there is a profound loss of dexterity.
Okay.
Which means they lose the ability to grade force or control individual digits. So a patient might be able to broadly swat at an object on a table, but they absolutely cannot pinch a key or hold a pen.
Oh, wow. That's a huge loss of independence.
Huge. And then there is spasticity.
Yeah.
This is a velocity-dependent resistance to passive stretch.
What does that mean exactly in practical terms?
So if you are a therapist and you try to quickly straighten the arm of a stroke patient, the muscle violently resists and just locks up.
Oh, because of hyperactive stretch reflexes?
You got it. And finally, the fourth major issue we see is the intrusion of abnormal synergies. This is a pathological co-contraction of muscles.
Wait, I've actually seen videos of that specific symptom.
Right.
A patient tries to reach forward, right, which naturally requires the shoulder to flex and the elbow to extend.
Right.
But instead of reaching out, the arm just involuntarily curls inward, tight against their chest.
Yeah, the central nervous system basically loses its selectivity. The muscles fire in this bundled, totally uncoordinated pattern. It is an incredibly inefficient and just frustrating way for the body to move.
So let me make sure I'm visualizing this correctly for everyone. If the brain is the main command center, right, and the arm is the factory floor, a stroke essentially destroys the main highway, that corticospinal tract between them.
I like that analogy.
Are we using the spinal cord stimulation, or SCS, to build a brand new highway, or are we just finding a backdoor country road to get the signal down to the factory floor?
That backdoor country road analogy is perfect.
Okay.
The researchers surgically implanted 2 epidural leads in the cervical spine, spanning from the C3 level down to T1. Each of these leads has 8 tiny electrical contacts on it.
Got it.
But here's the trick. The intervention does not directly stimulate the motor neurons.
It doesn't.
No, because if you directly shock a motor neuron, you just get a rigid, unnatural muscle cramp. Instead, the stimulation targets the dorsal root efferents.
Wait, dorsal root efferents, those are sensory fibers, right?
They are.
They carry feeling from the arm back up to the brain. If the whole goal is to make the arm physically move, Why are we pumping electricity into the exact system that makes the arm feel?
It sounds backwards, right? But it works because the spinal cord is not just some passive relay cable. It actually has its own complex local circuitry. By delivering continuous electrical stimulation into these sensory roots, the device creates this excitatory background environment within the spinal cord itself.
It's hyping up the whole area.
Exactly. It sends a surge of electricity that loops right through the spinal interneurons and synapses directly onto the motor neurons. This essentially raises the resting membrane potential of those motor neurons, lowering their threshold to fire.
Oh, I see. So the motor neurons are just sitting there, primes, basically hovering right below the threshold of firing.
Yes.
That means whatever weak residual signals are still miraculously managing to trickle down from the brain's surviving pathways, those weak signals are suddenly strong enough to push the motor neurons over the edge.
Exactly. And trigger a fluid, natural muscle contraction. You are artificially amplifying the gain on the spinal circuitry.
That is wild.
And crucially, the patient still has to actively think about moving the arm for the movement to occur. That's what makes it a true neuroprosthetic, rather than just some automated muscle stimulator that twitches on its own.
That is just a brilliant hack of the anatomy. So let's do a quick recap of this first block for you listening. The main problem is corticospinal damage causing weakness, dexterity loss, spasticity, and bad synergies.
Right.
And the solution is cervical epidural stimulation that activates sensory fibers to prime the motor neurons. So my question to you, the listener, is this. Have you ever considered that the best way to fix a broken movement system is actually by hacking the feeling system?
It completely flips how we approach neurorehabilitation.
It really does. But, testing this kind of hardware in living humans obviously comes with massive regulatory and safety hurdles.
Massive. The FDA only allowed 7 participants for this first in-human feasibility trial.
Only 7?
Yeah, and they mandated some incredibly strict limitations. They classify this under a non-significant risk limit.
Which means what exactly for a trial?
For an implanted epidural device, it means a hard stop at exactly 29 days.
Wow.
Yeah, the implants had to be surgically removed after 4 weeks, absolutely, regardless of how well the patients were doing.
That is heartbreaking, actually.
It is. And keep in mind, all 7 participants had profound chronic motor deficits. We're talking about individuals who scored between 15 and 35 on the Fugl-Meyer assessment, the FMA.
And that's a 66-point scale, right?
Right, grading motor function. So these scores are very low. Many were years, even a full decade post-stroke.
So that 29-day limit creates an incredible bottleneck for the researchers.
Very much so.
During those 4 weeks, I read that these patients only completed an average of 8.6 total hours of motor activity with the device active. 8.6 hours.
It's tiny.
Right, because if we look at vagus nerve stimulation, or VNS, which is another relatively new neuromodulation therapy for stroke, the protocols there require around 100 hours of repetitive physical therapy over 6 weeks just to move the needle.
Yes.
Getting real functional results in under 9 hours of therapy is just unheard of.
It completely highlights the immediate efficacy of spinal cord stimulation.
Yeah.
But we do have to talk about safety, because navigating the placement of electrical leads that high in the cervical spine was not without incident.
Right. This is where we need to talk about participant SCS-R4.
Yes, SCS-R4 is the critical case study for safety here. He was a 43-year-old male, about 5 years post-stroke.
Okay.
During the initial mapping phase in the clinic, where researchers test individual electrical contacts to try and isolate specific muscle responses, they activated a contact position high up at the rostral C3, C4 spinal levels.
Very high up the neck.
Very high. And they pushed the stimulation amplitude up to 5 milliamps.
And he experienced sudden shortness of breath.
He did. The clinical team had to immediately kill the stimulation.
Yeah, and for those of you trying to picture the anatomy here, there is a classic mnemonic that medical students use to remember this. C3, 4, and 5 keep the diaphragm alive.
A lifesaver of a mnemonic.
Seriously. The phrenic nerve, which is the sole motor control for your diaphragm, the actual muscle that physically pulls air into your lungs, originates right at those high cervical levels.
Right.
So by dumping 5 milliamps into that exact junction, they accidentally co-activated the phrenic nerve.
Exactly. The electrical field spread beyond the targeted dorsal roots and captured the phrenic motor fibers. It's actually a known risk of high cervical epidural stimulation.
So let me play devil's advocate for a second. If I'm sitting on the Institutional Review Board, the IRB, and a device just momentarily paralyzed a patient's ability to breathe, my instinct is to shut the entire trial down immediately.
Sure.
Why wasn't this a fatal blow to the whole study?
Because the researchers didn't hide it, right? They immediately reported the adverse event to the FDA. And more importantly, they demonstrated that the technology was adaptable.
They proved they could fix it.
Exactly. They updated the trial's safety algorithm basically on the fly. Moving forward, the new protocol dictated that if they were stimulating those specific high cervical contacts at a frequency above 20 hertz, the amplitude was hard capped.
Cap it so it doesn't spread too far.
Right. It could never exceed 3 milliamps. And this proved to the FDA that while the spinal cord is a super dense, high-risk environment, the mapping process could be tightly controlled and dynamically adjusted to preserve patient safety.
Honestly, it's just a massive testament to the bravery of those first 7 patients.
Truly.
I mean, they are literally letting scientists map their spinal cord's fuse box, right? So here's a quick recap of Block 2, 7 brave participants, incredibly low rehab hours required for results, and the crucial C3-C4 aphrenic nerve safety pivot.
Perfect summary.
So I have to ask you listening, would you be brave enough to be one of the first 7 human beings to let scientists test out your spinal fuse box? Because that bravery yielded some of the most fascinating functional data I've ever seen in this space.
Oh, the data is remarkable, but looking at it, the researchers actually split the outcomes into 2 very distinct categories, which is important to grasp.
Okay, lay them out for us.
They divided the results into assistive effects and therapeutic effects.
And the distinction matters because
Because it defines the ultimate utility of the device. Assistive effects are immediate and they happen concurrently with the stimulation.
So when the switch is on?
Right. The device is on, spinal cord is primed, and the patient experiences an immediate functional gain. Got it. Therapeutic effects, however, represent actual neurological healing or neuroplasticity. This is measured when the device is completely OFF, but the patient's baseline function has still magically improved compared to day 0.
That's amazing. And to help you remember how these work together, think of the ACT of recovery, right? Assistive plus continuous use equals therapeutic improvement.
ACT, I love that.
It's a great little mental hook. So let's dive into that assistive data when the switch was flipped on in, because the numbers are just staggering.
They really are. They measured maximum voluntary contraction, or MVC.
Which is what exactly?
It's basically the raw torque a patient can naturally generate around a specific joint. And across the shoulder, elbow, and hand, the MVC strength increased by an average of 32%.
30% instantly.
Instantly. And grip strength alone jumped 55%.
That is life-changing. But raw strength is really just a metric for muscle recruitment, right? It doesn't translate directly to functional independence, because if you want to, say, drink a glass of water without spilling it, you need dexterity and trajectory control. You can't just forcefully smash the glass into your face.
Precisely. And to quantify that dexterity, the researchers utilized something called a kin arm.
A kin arm?
Yeah, it's an exoskeleton robot that supports the arm, basically negating gravity, and it uses augmented reality to test reaching and pulling kinematics.
So this is where we actually see if the patient can steer the vehicle, not just, rev the engine.
Exactly. And with the stimulation on, the kin arm data showed that reach and pull trajectories became quantitatively straighter and smoother.
Wow.
The erratic sort of jagged movements typical of a stroke patient entirely smoothed out into intentional directed motion.
Okay, but wait, this brings me back to those abnormal synergies we discussed earlier.
Yes.
If stroke patients naturally suffer from their muscles fighting each other, like the bicep flexing hard when the triceps is trying to extend the arm, how does dumping a bunch of excitatory electricity into the spinal cord not just cause all the muscles to fire at once and make that synergy even worse?
Such a good question. And the electromyography, or EMG, data provides the answer. It reveals the profound elegance of this therapy.
Because EMG measures the actual electrical firing of the muscles.
Right. So the researchers analyzed the ratio between the triceps brachii, the extensor, and the brachioradialis, the flexor.
Okay.
In the pathological stroke state, these 2 muscles co-contract, they fight.
Right.
But when the spinal cord stimulation was active, the EMG showed the triceps activity amplifying, while the brachioradialis activity was actively suppressed.
Wait, really? It's actually suppressing the opposing muscle?
Yes. The dorsal root stimulation isn't just some blunt force instrument stepping on the gas pedal. By activating the sensory afferents, it engages the natural reciprocal inhibitory circuits within the spinal cord. It excites the intended muscle while simultaneously signaling the local interneurons to inhibit the antagonist muscle.
So it literally takes the foot off the brake so the joint can open up.
Exactly.
Here's where it gets really interesting, because Pulling off that kind of reciprocal inhibition requires millimeter precision, or what the paper calls selectivity. If we look back at participant SCS-04, the researchers found that when they stimulated contact 8R, which sits down at the C7 vertebral level, his elbow extension improved beautifully. The triceps engaged, the arm straightened out.
Right, highly selective.
But when they moved the stimulation just a tiny bit higher, up to contact 5R at the C5-C6 level, it accidentally recruited the biceps instead.
Yeah.
And since the biceps flexed the elbow, this completely hindered his ability to extend his arm.
It perfectly illustrates why a one-size-fits-all approach is literally impossible here. The spatial resolution of the electrical field is paramount. You have to tailor the exact millimeter of stimulation to the specific anatomical deficit of that individual patient.
It's hyper-personalized.
Extremely. You have to balance the excitation of the weak muscle with the precise inhibition of the spastic muscle.
All right, time for a quick recap of Block 3. Just remember, the ACT of recovery assistive plus continuous use equals therapeutic improvement. And the secret sauce here isn't just adding power, it's the device's ability to selectively inhibit opposing muscles so they stop fighting each other.
Spot on.
So think about the muscles in your arm right now as you're listening. How hard is it to consciously isolate just one muscle without the other moving? That invisible battle is exactly what these patients are fighting every day.
And speaking of that invisible battle, spasticity is arguably the most painful and persistent part of it.
Oh, I can imagine. Just having your arm locked in a constant, rigid state of tension must be exhausting.
It is. The clinical standard for measuring that tension is the Modified Ashworth Scale, or MAS.
Okay.
And over the 29-day trial, the average MAS score across all participants dropped by 2.1 points.
2.1 points? How does that compare to, normal treatments?
2.1 drop is actually highly significant when compared to current gold standard interventions.
Really?
Yeah. For severe spasticity, clinicians often rely on injecting botulinum toxin Botox directly into the muscle to cause localized paralysis.
Right, sure.
That intervention yields an average MAS drop of about 1.5 points.
Okay, so 2.1 is noticeably better than 1.5.
Much better. And for more systemic spasticity, patients undergo actual surgery to implant an intrathecal baclofen pump, which continuously delivers muscle relaxants right into the spinal fluid.
That sounds intense.
It is, and that provides a drop of around 1.4 points.
Wow. So we have an electrical intervention wildly outperforming highly invasive chemical and surgical interventions, and it does it without all the systemic whole-body side effects of a heavy muscle relaxant. That is just a massive win. But it inevitably leads us to the big triage question, right? Who actually benefits from this? Yes. Because if a patient is 10 years post-stroke and their arm is completely flaccid, is this hardware going to do anything for them, or is it hopeless?
The paper dedicated a huge amount of analysis to this exact question. They were looking for the determinants of responsiveness.
What makes a high responder?
Right. And the conventional wisdom in neurology is that baseline motor impairment dictates your ceiling of recovery.
Meaning if you start bad, you end bad.
Essentially, yeah. If you start with a terrible motor score, your potential is severely limited. But this trial found the exact opposite.
See, this was the absolute aha moment of the paper for me.
Yes.
Let's look at participant SCS-02. She had a baseline motor FMA score of just 15. That is profound, severe impairment.
Very severe.
And the device, to be felt, didn't miraculously restore her fine finger control, but despite that incredibly low baseline, she still experienced massive improvements in her overall arm dexterity, strength, and spasticity relief. Her profound inability to move at baseline didn't disqualify her from the benefits of the device.
And that's because the biological prerequisite for this specific therapy isn't intact motor fibers.
What is it then?
It's intact sensory fibers.
Ah.
The researchers discovered that patients who maintained a baseline sensory FMA score above 5 were consistently the high responders.
Wow. Sensory FMA above 5?
Yes. They retain the ability to feel light touch and proprioception, which is your sense of joint position in space. If those sensory pathways are intact, the epidural stimulation has the required biological hardware to loop the electrical signal back into the spinal cord's motor circuits.
So to see what that sensory prerequisite actually translates to in the real world, beyond just robotic exoskeletons, we can look at participant SCS-0.
Her data. is incredible.
She was a 61-year-old female, a full decade post-stroke, 10 years.
A decade.
And they ran her through the box and block test, which basically requires a patient to move small wooden blocks over a partition in 60 seconds. At baseline, with the device completely OFF, she struggled to move just 4 blocks. The moment the device was turned on, her score instantly doubled to 8 blocks. She regained the ability to simulate opening locks, manipulating kitchen objects, and moving dynamically in 3D space.
It's beautiful, but the reality of the trial design brings us back to a pretty sobering caveat.
Right, the explantation.
Because of that FDA non-significant risk classification we talked about, SCS-07 and all the other participants had to have their devices surgically explanted after 29 days.
Such a bummer.
When the researchers followed up a month after the explantation, they found that while some minor therapeutic improvements remained, so there was some neuroplasticity, the patient's functional motor scores had dropped significantly compared to their peak performance when the device was on-an.
The assistive magic was gone. So let's recap this final subtopic. Your motor baseline doesn't disqualify you, but your sensory integrity is the absolute secret weapon.
Exactly.
Plus, the device clearly acts as a permanent neuroprosthetic since the scores dropped once it was taken out. So, if you were designing a therapy, would you have ever guessed that the patient's ability to feel would dictate their ability to move?
It really is an incredible finding.
So what does this all mean for the future?
Well, if we connect this to the bigger picture, it means this technology fundamentally changes the paradigm of post-stroke neurostimulation.
Okay.
It is not meant to be a temporary set of training wheels. It's not vagus nerve stimulation where you use it for 6 weeks to force neuroplasticity and then turn it off and you're cured.
Right.
We are looking at a fully implantable, permanent, daily use neuroprosthetic. It parallels the use of deep brain stimulation, or DBS, for Parkinson's disease.
Oh, that's a great comparison.
Yeah, because a Parkinson's patient doesn't use their DBS implant just during physical therapy. They leave it constantly active so the tremors stop and they can actually hold a cup of coffee and live their life.
It's always on.
Exactly. This cervical spinal cord stimulator is designed to be a permanent, daily use bridge over a chronically broken anatomical highway.
It's basically an invisible crutch that allows a stroke survivor to reach out and hug their family again. Which leaves us with one final, very provocative thought for you to mull over today.
Let's hear it.
If the sensory pathways are the ultimate backdoor to hacking motor recovery, if we can bypass a destroyed motor system simply by pumping precisely calibrated electricity into the feeling system, what other incurable movement disorders are out there right now?
That is the billion-dollar question.
Could we potentially treat spinal cord injuries or multiple sclerosis or even ALS simply by learning how to properly talk to the sensory nervous system?
It demands that we completely reevaluate the entire architecture of the nervous system. I mean, we have spent decades trying to fix the broken wires.
Yeah.
Now we are finally learning how to use the wires that are still intact to override the broken system entirely.
It's an entirely new frontier of neuroengineering, and it is endlessly fascinating. So next time you wake up and stretch your arm, take a second to appreciate the incredible, invisible electrical loop that makes it happen so effortlessly, and consider what it takes to rebuild that loop when it breaks. Thank you so much for joining us on this deep dive. Stay curious, keep asking the hard questions, and we will catch you next time.